can I ask Wilco to start his talk? You can share the screen, Wilco.
Yeah. Do you see my screen?
Yes. Yes, please. Thank you.
Started with the end. So thank you very much. Well, Time is Spine is also the title of my presentation. It is Michael Velings, who is the big promoter of Time is Spine, but I think that most of us will follow him, although it is worldwide difficult to implement. And if you look at my conflicts of interest, most are sponsorships for trauma of the brain and trauma of the spine. And currently, I'm busy with a very big grant to look at early timing of surgery in the Netherlands and Belgium. So can we prove ever our point? Everybody knows that if there's a brain trauma, early surgery or early treatment or early decompression is advocated, although evidence is not very clear, but everybody agrees on that. And for spine, it might be different. So if you look at North America, and they did a study in the travel to the hospital, and they compared brain injured patients with spinal cord injured patients, then there was a huge difference. In contrast to brain, spine patients waited sometimes for more than 1 day before they were treated in a level 1 trauma center. So it seems it's difficult. And if you look at history, the history is already from the ancient ages that people were treated by spine trauma, first by traction, sometimes by magical healing. But in the end, more than 100 years ago, they started doing surgery. And Cushing was the first one who described that 80% of patients will die if there's a complete spinal cord injury. And the first one who did a lot of good research was, again, from North America, Tater. I think he was the foregoer of Michael. And then after that, Michael took over and did a lot of studies. So if I look at my part of the world in Europe, it's a huge problem. The incidence is rising from 10.6 per million. It's rising to 17.8 per million in 2010. And it's even rising now, especially elderly people have a lot of spinal cord injuries. Having had a spinal cord injury, it means that people have lifelong disability, as you all know. Well, if you look at the incidence worldwide, you see that most of the spinal cord injury patients are not treated in North America or Europe, but in Africa, South America, and Southeast Asia. So whereas a lot of research is being done in Western society, most of the trauma cases are not in these countries. And that's a very big problem. And you see also that the availability of orthopedic and neurosurgeons to surgery of the spine, so they have the competence of spine, is in several parts of the world less good than you should expect for the need of the patients. So what to do? We have to care for our patients, and we want to prevent all those patients to go to the wheelchair. But if they are in the wheelchair, they need also good treatment. So my proposal is that internationally, also by this organization, we should promote doing more research in the countries who need it the most, and also train people in the countries that need it the most. And when we talk about timing a spine, it's completely different if I treat a spine patient here in my country, in the Netherlands, or in North America, or in a country like Suriname, where I also treat patients. It's completely different. So the same hands have more difficulties in other countries. So why is early timing of surgery so difficult to implement? Well, you see here in our own center recently, you see that a lot of patients are coming in with spinal cord injury, but if you treat them, in acute phase, it might sometimes be difficult. And the decompression is not that difficult, but the reconstruction might be difficult. So you need a good team. And if you don't have a good team at the middle of the night, then you can explain that some people say, well, I do the surgery the next day with my own people, a good anesthesiologist and a good surgery instrumentist. Well, we know that the effect is extreme on spinal cord injury. So patients, one day or the other, sporting, and after that, they are not able to sport anymore. So they, well, there's a huge need of good research. And Valerie Terwengel, one of our neurosurgeons, did good research on that. She said, why is it so difficult to decompress this spine, the sudden spinal cord injury, from a normal person to become a patient with disability? And we as surgeons can do something about that. So not always with very complex surgery, sometimes only decompression and the acute phase. If you are not able to instrument, you can instrument later. I won't advise that in my country, but in some countries that might be necessary. So the timing is quite important. And if you look to the reasons why we do it, I don't think that surgeons are lazy. But if you look at surgeons' fatalism, neurosurgeons and orthopedic surgeons were asked by Valerie, what do you do with a complete spinal cord injury? So Enrique just showed you the ACR score. If you have a complete injury, most of the surgeons won't do the surgery within 24 hours. Whereas if you look at C-spine injury of the spinal cord, then you see that a lot of patients are able to recover. So is it irreversible, or is sometimes a little bit reversible? And even a small portion of improvement might be very good for the patients. So C-spine injury is doing better than thoracic spine injury. Although we are in C-spine injury even more nihilistic as surgeons. Well, if you look at the systematic review, which was published in Journal of Neurotrauma in 2019 by the same Valerie Terwengel, you see that there is a reason to do early surgery. There's improvement. The improvement is not big. It's small steps, but huge steps for the patients themselves. So why shouldn't we treat patients in an acute phase like we do in a brain trauma or an abdominal aneurysm rupture or a gunshot wound? Even a Cauda syndrome by herniated discs are treated earlier than a spinal cord injury. So what Valerie did, they compared two different centers. And it was Amsterdam and Utrecht. And Amsterdam treated not very early and Utrecht very early. Utrecht is the clinic of Tumor Onur. A lot of people know him. He's an orthopedic surgeon, come from Turkey, but working for years now in the Netherlands. And Tumor and I myself were trained in Rotterdam, where we were not trained to do acute surgery. And some people make jokes that Tumor and I became a little bit aggressive after leaving Rotterdam. But what Valerie looked at is the treatment strategy of Tumor compared that to Amsterdam, where Amsterdam was quite late. And you could see that there was a significant difference. Not a complete recovery in spinal cord injury, but there is recovery. And it is statistically significant. So that difference might be small, but if it's more than one at the motor level or more than 2 points in AES, I can imagine what it means. And she asked the patients, what does it mean to you? What is the effect of the benefit? So we as surgeons might say, well, there's a small improvement, but not clinical relevant. But the patients, you see it, give a lot of benefit. I'm sorry, there's a lot of noise here now. I'm at a university. So can you still hear me? Yeah, I think so. Yeah.
Yes.
Yes, we
Yeah,
hear
okay.
you.
Yes.
Okay, I try to speak loud. So especially the hand function for C-spine injury, spinal cord injury, high C-spine injury, the movement of a hand or a grab function of the hand might be very important to help themselves, to clean themselves, to write. So although we sometimes think, well, it's a very small improvement, is that worthwhile the early surgery? For a patient, that might be very important. So even a very local, regional recovery is a great benefit for the patients. But if you look at all the studies, the study of Michael Veling's, his group, and you look at other studies too, you see that there's a difference for our patients. And there's no question mark anymore to do it within 24 hours if you are able to do that in your part of the world. So even if the outcome of surgery is not leading to recovery, you did do everything to treat the patient well. And if you can reconstruct the spine, the patient can also early be rehabilitated. So then research, how to do that. This is different than doing research for herniated discs, which I did in the past with an RCT, because those patients are the same. But spinal cord injury patients are very heterogeneous. The trauma is different, the person is different, and it's very difficult to compare oranges with apples. And that's also the difficulty in research. So one of the reasons why a lot of studies do not work is because differences between patients. So people in my country said, well, Wilco, you should do a randomized controlled trial comparing early to late surgery. So because in my clinic, we try to treat patients within 8 hours, not within 24 hours, but within 8 hours. And if you have to do a randomized controlled trial, then I should, if a patient is randomized to late surgery, then I should, as a surgeon, change my strategy. And it's very difficult for me because I believe in early surgery. So that's a risk of clinical equipoise. So I don't have equipoise about early surgery in these cases. So a randomized controlled trial, I don't think it will happen in the next few years. But what we can do is compare the believers and the non-believers. So what we start to do is in the Netherlands and in Belgium to start a study in which the clinics doing very early surgery comparing to the clinics believing in delayed surgery in optimal circumstances. So this study has been just started 1 year ago with a grant of the CSRS. And Charlotte Adegeest and Valerie de Wengel are the coordinators. But I think it will take 5 years until the first results are there. In between, I would say, look at your patient, collect the data, and do not wait too long with surgery. Having said that, I know that it's quite different. When I was at the course of Roger Hertel in Tanzania 1 year ago, nearly 1 year ago, I also presented this spinal cord injury, and I heard from the surgeons in Tanzania and Kenya and Uganda that they had difficulties to do that and that they have very high mortality rates because of different circumstances they treated the patients. So I'm not very sure if there is a solution, but as a society, spine society, we have to take care of that and also be able to improve treatment of spinal cord injury patients. Thank you very much.
Thank you, Wilco. It is a great overview of how the early surgery helps to the results. But do you think what is your comment about early surgery and late surgery?
Well,
In general, I mean, do you think in the first 24 hours it is early, or we must consider first 8 hours as an early surgery?
It depends on the department. So in my department, we have a separate spine duty, and we have the luxury of 11 spine surgeons in Leiden and The Hague. So then it is possible, and also a good OR team. And then I think the earlier the better, but that's not proven. We also know that there's a higher risk of early surgery. And if you ask me, Mehmet, you spoke to me years ago, I was very confident about it. But now, having been treating patients in different parts of the world, I think it's more difficult than I imagined. And looking at spinal cord injury in my hospital and in my region, there's a very low incidence, whereas the incidence in Africa, South America, and Southeast Asia is much higher. So I think that if you want to do that early surgery, you need all the circumstances in the right way. And not only the surgeon, but also the OR nurse, the scrub nurse, and the anesthesiologist.
Yeah, completely right. Yeah, we have actually we were having in the past more mortality rates if we operate in the night time. Although we did not make a good study on that, but it was generally true. I think Edwin wants to ask something.
Yeah.
Edwin, you can unmute. Edwin.
Hello, sir. Thank you for the opportunity to speak. So my question is, if the patient has complete STI, pneumothorax or hemothorax, wound contusions, should we prompt to do early surgery, or we should wait for the general status to get better to do the surgery? What is your opinion in these cases? Thank you.
Well, that's a very good question, and I'm not very sure if we have an answer to that. But if the patient has long contusions and pneumothorax, and it's difficult to be on the ventilator, lying on his belly in prone position, then it might be difficult. We try to do it, but sometimes the systemic problems are too big, and then we have to abstain from early surgery, indeed. But we don't give in too quickly, because anesthesiologists sometimes say, well, it's dangerous to do early surgery. Well, it's also sometimes dangerous to have a patient long lying in his bed. But you are right, if there's a multi-trauma case, it sometimes is difficult. The same is for brain-injured patients. If you have a severe brain injury with high intracranial pressure, and you want to do a posterior cervical decompression fixation, that might have an extra risk.
Yeah, good. Wilco, there is one question from Dr. Javier Altamirano Cruz saying that what is your comments about the decompression with duroplasty versus decompression alone?
Yeah, we will do. It's a very good question, because it's quite actual now. Everybody knows Samir, the lady from London. She started the study together with her husband. Her husband is the neurosurgeon, and we are also involved in the study, starting just now. I'm not very sure. It's extra risk to duroplasty, but I can believe that in certain patients it might help, because you do a bony decompression and sometimes you have a swollen spinal cord. But I'm not sure it helps in every patient. So that's one of the risks, because in my hospital, so we also start with the study, but in my hospital, the half of my spine surgeons are not willing to do it. So I don't know what other people think, what you think, Mehmet and Enrique, about this duroplasty.
I have no idea. Actually, in the past, I know some surgeons were doing that routinely, but I don't know the outcomes of them. Enrique, what do you think? You can unmute, Enrique. You must unmute yourself.
I don't use normally, and I don't have experience, and I don't know if it's useful or not. Really, I don't know.
I think also it's prolonging surgery quite big. So people think, well, a duroplasty is like in the skull, but it's quite difficult surgery. So especially in a trauma patient, it's bleeding. You open up the dura. I'm also a little bit afraid that we make more damage. But having said that, I start with the study too. So I believe in the idea. Yeah.
Good.